couple people over here that fall asleep. Not that I'm keeping track of anything. All right. So, yeah.
I don't know if other years have struggled with it, but I think it's challenging for us because PathoFizz has also moved to Mondays, so our Mondays are super long. So
Okay.
I think that is like part of the, like we had from 8 o'clock test to like, and then we're lecturing only till 5.
Okay.
But like, I think that might have been a shift from past years.
I mean, PathoFizz starts at like 10:30.
Yeah.
Yeah,
normally pretty late.
It depends on
And we're in for it.
Yeah. Yeah, and I know that we've tried to
normally,
not stack it up.
yeah,
but-
PathoFizz used to be on Tuesday, but then Becky had to move it to Monday this year because of like childcare.
Sure.
So then it just made
So
that
that just
long.
makes it long.
And then you just happened to be at the end of it. So.
Right, I know. That's where when I switched this to an afternoon, I used to do a morning session, but it just didn't really work out with my new job. So anyway.
Yeah, that was good.
I get it. But, okay. Well, we'll try and get through some of this today. I'm not sure if we'll cover every single aspect, but we'll do what we can here. So, acid suppression, there's a couple different drugs. We've talked about a few of them already, and some of them within context of other treatments. So, like we mentioned, proton pump inhibitors with respect to H. pylori infections. And we've talked about histamine 2 blockers already briefly. And I'll talk about them with respect to GERD and general acid suppression. So, your physiology, you're looking at the human stomach and shutting down the way it produces acid. So you've got parietal cells which secrete hydrochloric acid, and they do that via a number of different mechanisms. And so we can target them differently, work in different mechanisms of action to shut down at least some of the production of acid to either make people more comfortable or prevent ulceration. So acetylcholine, histamine, and gastrin are the three major workers in this area. So we'll get to that in a second. But primarily what we're looking at is a couple drugs that work a little bit outside the system. So histamine, certainly we've talked about that. That's a big player that we can manipulate pharmacologically. Acetylcholine, we aren't going to really do a whole lot with anti-muscarinic drugs. It's just because of their side effects in the GI tract, they aren't really the most tolerable ones, and we have better medications out there. So yes, anti-muscarinic drugs would theoretically shut down acid production, but we just don't use them for that. And then gastrin, there isn't really any drugs out there that manipulate gastrin directly, so it's not really something we're going to talk about, but it is part of the physiologic approach to it. So I'm going to skip this slide with the fancy drawing and go to this nice box slide, which shows a parietal cell in the form of rectangles, which I like. It's simple. So anyway, you have, this is your stomach here, and you've got your proton pump finally, which is releasing hydrogen ion into the stomach, secreting hydrochloric acid. So why am I showing you this? Because we have two major drugs, which are H2 antagonists, and our proton pump inhibitors work two different ways. So the proton pump inhibitor is going to block the final step in acid secretion. So we'll get to where these drugs are used and why some are better than others. But the point is that they're different. So histamine 2 receptor blockers are going to block this histamine receptor, which can be triggered by gastrin and acetylcholine, and is going to be part of the mechanism that's going to trigger a proton pump to release hydrogen ion. Now, you can see that gastrin and acetylcholine can also do some sub-mechanisms themselves and go around the way that histamine works. So the point is that histamine is not the final step the proton pump is. So that should give you a clue right away. Proton pump inhibitors are more potent, generally more effective. The histamine blockers are quite effective on their own as well. We'll talk about where we're going to use these. One thing that's a little confusing about this drawing is it makes it look like proton pump inhibitors kind of work in the stomach. They don't. They actually do have to get absorbed through the body and then get to the site of action. So they're actually kind of coming in the back door, or the front door, I guess, depending on how you want to look at the cell. And then histamine would be working the same way. So these medications don't work locally, is my point. They do get absorbed and have to move around systemically. So you'll see products that are proton pump inhibitors often labeled as delayed release or something like that. That's because they're delaying their release to the stomach and they're absorbing in the GI, in the small intestine. Okay. This is just some background information. It's not super important other than basically what I just said. The hydrogen potassium ATPase surface on the parietal cell, that's your final pathway, that's your proton pump. And so when we talk about PPIs, they're blocking that hydrogen potassium ATPase there. And histamine 2 receptors blockers are just doing that. They're blocking the histamine 2 receptors on the parietal cells. Okay, so let's start with PPIs and talk about them in a little bit more detail. So they are the most potent inhibitors of gastric acid secretion. They're very effective. Usually you take them before breakfast, so on an empty stomach. And the reason is because you take them, you want to get them through the stomach into the intestine where they can absorb, because you want them to be well absorbed by the time you consume a meal. So the idea is that once you start eating, your body starts activating that ATPase, and then your drug is already hopefully absorbed into your systemic circulation, and then it's going to work on those active ATPases to shut them down. Most people take them once daily, so they're relatively convenient medications. They inhibit acid output by about 66% after 5 days. So you're never going to shut down every single parietal cell. It's not possible, but you can get a majority of them shut down, and that's going to really change the pH substantially enough to either A, give a better healing environment, so ulcers can either be prevented or heal, or B, just prevent things like heartburn from occurring or chronic reflux from occurring. PRN usage of proton pump inhibitors is not reliable or recommended. Proton pump inhibitors take a few days to actually work, so usually the first day you take a proton pump inhibitor, you might feel some effects, but the full effects are going to be after about 5 full days of dosing. So I hear this all the time where patients are like, yeah, I take my Prilosec as needed. I'm like, well, there's better options, probably like H2 blockers, which we'll get to in a second here. But anyway, for proton pump inhibitors to be used effectively and correctly, scheduled dosing is most appropriate. BID dosing sometimes is an option, and you might see BID recommendations for certain things. So like if they have, what's an example? H. pylori infections, for example, is BID dosing. Some of the more complicated things, like maybe a more severe history of ulcers or people with really bad reflux that aren't getting controlled, you will see these dosed PID, but just know that once daily is good for the majority of patients out there. If you stop them or miss a dose, they do have sustained effects, so that's a nice advantage of the medication. And they all the PPIs share a similar chemical structure. There's not one that's really better than the other. And this is what they are. Oops, anyway. They all end in prazole, and they're pretty easy to recognize. And they're, again, nothing's better than the other. There's a little bit of a difference in cost, potentially, which I'm not really going to get into too much. Other than that, some of these are over-the-counter. So Prilosec, Nexium, and Prevacid are all OTC. The rest of them, Acifex and Protonix, are RX only. Dexilent is a new one. So you can see Dexilent is just the Dex version of lansoprazole. I'm not exactly sure why they made this drug, because I don't really understand the purpose of it, but it does exist. I don't think I've ever seen it prescribed to somebody. I mean, you have a number of options here. So some way that I've seen people cheat a little bit with insurance companies. So because these 3 primary ones, so these are big drugs that were prescription for a long time, and they've all recently gone over the counter. Well, not recently. I mean, I think Prilosec's been OTC for almost 10 years. But relatively recently compared to the life of the drug. What you'll see is insurances won't pay for it because they're on over-the-counter status. So they'll ask the patient, no, that's OTC, you have to pay for it out of pocket. Well, you could prescribe pantoprazole, which is a prescription product, and the insurance might actually pay for it. Or they might come back and say, nope, I understand what you're trying to do, you're trying to trick us, prescribe omeprazole and make your patient buy an OTC, or over-the-counter. So it's a way you might be able to get insurance to pay for it, but don't guarantee it. We use pantoprazole as our formulary agent at the hospital because it's our cheapest one we can buy. So that's the only reason. So you might see certain health systems prefer one drug over the other. That's usually just a financial decision, not necessarily an efficacy decision. Yes?
I was just wondering which ones are over the counter.
These 3, 3 middle ones: omeprazole, esomeprazole, and lansoprazole. And some of them, I think, like Prevacid went more recently than Nexium or Prilosec, so you'll see Prevacid as more of a branded product, but you can buy a generic omeprazole over the counter. It's still not super cheap though, so I mean, you're still paying, I want to say it's like 10 or 20 bucks for a box of it. Dosing, I'm not going to test you on dosing of PPIs, but this is just the equivalence thing. I think it's a nice thing to have handy. In any practice you work in, you're likely going to run into patients on proton pump inhibitors, so understanding how to convert from one to the other, because you might have a patient who, again, needs a change for insurance reasons. You know, they might have switched jobs, and their new insurance coverage wants them to be on lansoprazole, and you're like, okay, they're on 40 of omeprazole. How much of that is lansoprazole? And you can kind of use these ranges as a tool. So low end of the range, generally equivalent to the high, and the high end of the range, generally equivalent across the board. So again, like 20 of omeprazole is about 15 of lansoprazole. You can see that it's not too bad. Most of them are 20, except for lansoprazole is really the odd one. Remember, dexlansoprazole isn't a very common medication, and I highly doubt you're going to find an insurance company that wants to pay for that. But if you want to try it, I'd make sure your patient has failed most of these other options or hasn't gotten good results with the rest of them. All right. Just a little bit more information. So omeprazole is the oldest and most common one. It's been over-the-counter and generic longer than the rest of them, so it's probably the most popular one. I just wanted to point out something. If you ever read the over-the-counter packaging on these, sometimes they'll say things like, don't use for more than 14 days. And we associate PPIs a lot with chronic use. A lot of people take these as years and years, and they just take them every day. Either it's because they decided to and they liked it because they don't get heartburn anymore, or because they have a chronic actual diagnosis for it. So is it designed for 14-day use? Technically, yeah. So it's designed for short-term use for OTC purposes, but there's definitely indications that are okay to use longer. So if you see that on a box from the OTC packaging, just know that they do that. And I don't know if that was the legal requirement for them to get OTC, that they had to label their products for short-term use only. And there are some chronic issues, which we're going to get to in a second here, but it's just something to be aware of. Yeah.
Does anyone get heartburn for just 14 days?
Yeah, isn't it a chronic condition?
It depends. Depends on the source. So, like, what if you, I mean, you can make an argument for a number of things, but yeah, you're right. I mean, what is it that is causing your very short-term heartburn, potentially? Yeah. It's an interesting conversation. But I don't know why they do that. But yeah, 3 14-day courses of treatment. So they even give you it in 40. Anyway, yeah, it's strange, believe me. So anyway, the rest of these, I don't really have much to say other than esomeprazole and pantoprazole are available IV, which we'll talk about a little bit in a second here. But the nice thing is that for people with like a severe GI bleed, anybody with a GI bleed, we want to decrease the pH, increase the pH as much as possible. We want to make it less acidic. So continuous infusions are ideal for that. We'll touch base on those here in a second. All right, drug interactions. PPIs, because they're so common, have gotten a bit of a bad rap with drug interactions. Most of them are CYP metabolized, and what you get are differences in how ethnic groups will process them. Some patient populations might have no issue with them, others might have some. Pantoprazole is generally thought to have the lowest risk of causing any drug interactions or problems. So if you have a patient maybe on like a transplant medication that might be at risk for a drug, something that would maybe have some clinical significance for a drug interaction, that might be a patient that pantoprazole would be a better drug for. But overall, a lot of these interactions that flag for, you'll see when you put drugs into a database or you order a new drug for your patient, a lot of times you're going to see flags for PPIs, and most of them aren't really clinically relevant. We just don't really care. One story I'll share is with Plavix, and maybe I already talked about this, but I'll say it again because it's more relevant here. Plavix is the prodrug, right? So it has to get metabolized into its active form to have antiplatelet activity, and omeprazole technically interferes with the way that that's metabolized into its active form. So the idea is that you take clopidogrel and omeprazole at the same time, there's that interaction. You just might not get as high of blood concentrations of clopidogrel. And we know that pretty well. That's a pretty well-established interaction. There's some evidence. There was one big paper that came out that said this is bad. Everybody needs to stop prescribing PPIs with Plavix. And so all the cardiology community changed all their patients over to histamine 2 blockers who were on these drugs. Now there's another study that came out that I don't think was the greatest study, and its end outcomes are a little weird, but it's generally accepted that this isn't clinically relevant. They basically show that yes, this does affect the drug, but clinically we aren't seeing any differences in outcomes with it. So ultimately you can give these two together, but just know that there is a and you'll see these drugs flag on all types of interaction screenings. So the point is that people do take clopidogrel and omeprazole now together. There was a scare for a while where no one wanted to do it. All right, safety. So these are over the counter, so they must be extremely safe, right? Well, actually, not really. There's some interesting issues that are showing up with chronic PPIs. So ultimately, the moral of the story is that some of this stuff is a little bit theoretical, but if you don't have to give your patient a chronic PPI, you shouldn't give your patient a chronic PPI. So it's always good to make sure that your patient actually has a reason for taking the drugs they're on. So if they come in and they're on omeprazole and you don't see a diagnosis for GERD or anything like that on their chart, it's a good question. Why are you taking this? Is it something that you feel like you need, or did your friend recommend it, or did you have a week where you were, I don't know, eating a lot of Mexican food or something and it just didn't agree with you? Who knows what it was that prompted it, but is it something you need to continue? A lot of times one of the problems we see is people get started on these in the hospital. If you're not mobile, you have a higher risk of stress ulcers, especially if you're an ICU patient. So we see a lot of our patients come out of our ICUs on some sort of a prophylactic regimen of either a PPI or H2 blocker, and they just never get taken off of it, even though they aren't at risk anymore, and they never needed it in the first place for a chronic condition, just for that acute instance in the hospital. So anyway, this stuff does stick around in people, and people will just take it if no one really intervenes on that. So it's an important intervention I think to make. But back to the safety risks. Enteric infection risk is the biggest thing, and we've actually seen increases in C. diff rates as a pretty good, there's pretty good correlative evidence that people who take proton pump inhibitors regularly have a much higher risk of acquiring Clostridium difficile. So our stomach is a good barrier against bacteria getting into our gut and wreaking havoc. So if we are taking that barrier down, that can, of course, put us at risk for different enteric infections. So generally speaking, in developed countries, we aren't consuming a lot of salmonella or anything like that, hopefully. But C. diff is still one that, regardless, it's a problem. And you're seeing potentially compounded risk if somebody's on an antibiotic and they're already at risk for C. diff infections. Then you're adding something on that's also putting them at risk. That's sort of a double problem there. And when we compare them to H2 blockers, it's a higher risk with PPIs. So maybe it's some higher potency, but they do have that risk that goes with them. So just something to consider. Some of this other stuff is, again, the C. diff risk I think is pretty real. This is a little bit more theoretical. Pneumonia, the idea is that pathogens might be able to colonize the upper GI tract more so if your pH is higher. And so the idea is that if you aspirated something, you're more likely to get bacteria and other contents into your lungs, so potentially higher risk for pneumonia. Again, not like the best evidence, it's just more of a theoretical thing there. Malabsorption is possible, so lowering, decreasing your body's ability to, or changing the pH of your GI tract can affect certain absorption. So specifically vitamin B12 and iron need acidic environments to absorb fully, and so you probably are going to lose some absorption, but for most people this isn't really clinically significant. For patients who are vegan or vegetarian who just don't get as much B12 naturally and sometimes don't get as much iron naturally, that could be a problem, especially if they're supplementing and it's not absorbing correctly. Some of this other stuff, hip fracture and calcium absorption. There is some evidence that shows that patients on PPIs have higher incidences of hip fractures, but I don't think we've really nailed that one down with evidence yet. And there's some risk, or I shouldn't say maybe conspiracy theory, that's not a good word either, but people thinking that PPIs cause cancer because high gastrin levels in rat models were shown to increase tumor load. This hasn't been seen in humans, and they haven't been able to replicate that data, fortunately. So I don't think that's a huge risk to worry about. But you might hear that the PPIs cause cancer. It's animal models, and we have to really take that with a grain of salt if we haven't seen it come up in humans yet. Okay, histamine 2 blockers. So H2 blockers work a lot faster than PPIs, so you get relief in about 30 to 60 minutes. So for patients who want to take something as needed, I highly recommend these over proton pump inhibitors. One, they're cheaper. They have less two, they have less side effects, and three, they work like that's intended use. It's as needed. You can take these chronically, and yes, they're slightly less potent than PPI, but for the person who gets occasional heartburn, I highly recommend using these over PPIs. It's just going to be more effective for the patient and safer in the long term. They are renally eliminated, so you do run into that risk potentially of having to dose that, but for the most part, there's not a whole lot. Usually you just would dose it once a day versus twice a day. It's not a big deal. It's not like it's a contraindication to give it to somebody with decreased renal function. Some of the risks you'll see, you'll read that they have the same risks, like they cause C. diff and other enteric infection risk. Again, it's lower, and the evidence isn't as robust to support it than PPIs. But still, theoretically, it's the same mechanism that's causing this, right? So you're altering stomach acid production, and that would apply to anything that's doing that. So theoretically, it's there. It's just not seen quite as much with the evidence we have. These products are all over the counter, and there are different prescription strengths available, but you can just double up on the OTC one. Possible complications, so very rarely hepatic dysfunction, bradycardia, maybe CNS. This would be mostly in overdose or for people who have renal dysfunction, and specifically with one of the drugs. So Selfmedicating is the one that has probably the most side effects, and it's been associated with some of the CNS disturbances, specifically in elderly patients with decreased renal function. Famotidine and ranitidine have very few side effects to speak of, that outside of the general acid suppressing enteric risk. They're pretty well tolerated across the board. Famotidine and ranitidine also come IV and PO, so it's easy to convert 1-to-1 between the two, and you're able to use the drugs for both inpatient use and outpatient use, and they both work very similarly. They have fast absorption, either IV or PO, so it's a nice way to convert somebody from one regimen to another without really having to think too hard about it, which is always something I like when you can go IV to PO very easily. Twice daily dosing. So if you are going to take these chronically, it's always going to be BID unless you have renal dysfunction, whereas PPIs you can generally get away with once daily. Clinically, there's not a difference between the three of them. They all have equal amounts of evidence for them, and they're considered sort of an alternative to PPI. But remember, what my recommendation would be for anyone using it as needed, H2 blockers would be the drug of choice there. So other things, we have antacids. So antacids are things that just neutralize acid on contact temporarily. These are going to be your things like Rolaids or Tums. So usually they're calcium products, calcium carbonate. Rolaids has calcium carbonate combined with magnesium hydroxide. Gaviscon has aluminum and magnesium. They're all just acid neutralizers, and none of them will absorb too much. You might get some calcium absorption, some mag, some aluminum, likely not enough to cause any clinical significance. Sometimes you'll have people who take Tums regularly to get their calcium intake in, and if you take, like 500 or 1,000 3 times a day, which I've seen people doing, you're going to absorb some of it. But calcium carbonate isn't the best form of calcium to absorb. Some of the other forms are better, but you will get some calcium supplementation with it. Are you going to get hypercalcemic? Very unlikely. Sulcrafate or carafate is this polysaccharide product that binds to the injured gastric tissue. So essentially you can think about it as covering up an ulcer and allowing it to heal so that acid can't damage the tissue further. So it's something you'll see maybe used if somebody does have a peptic ulcer. It's generally a short-term thing, and it's usually dosed 4 times a day. It's kind of either these really big pills or really thick liquid, and I don't think it tastes great, so not the most convenient medication, but is an option for patients. And then Pepto-Bismol or bismuth subsolate does not really have any gastric acid alteration properties, but it does suppress H. pylori and the ability of H. pylori to cause a GI ulcer. So there's maybe some advantage there with that. But for acute acid suppression, not really going to be a beneficial medication. Yes?
You double up these with the other one?
Yes. Yep, definitely. Yeah, and sometimes you'll see even like Pepsid products or branded products that are combined with calcium chloride, where they're like chewables, and it's the drug plus some sort of an antacid. So yeah, you'll see that combined as well. Yep, certainly.
Does that include the PPI or just the H2?
You could do it for PPI. What I would do is just follow that empty stomach policy, so don't take them at the same time. But if you had heartburn throughout the day on the PPI, maybe after lunch or something, you could certainly take something. I think it would be fine. All right, so GERD is the most common thing people are going to take these medications for. It's gastroesophageal reflux disease, or commonly known as heartburn for most patients. Treatment basis is usually we're looking at frequency and severity of symptoms, or if you're getting to the point where you're getting some erosive qualities within the upper GI tract due to the increased acid and reflux, that would be a more severe case. The idea is we can suppress the acid, suppress the symptoms, and hopefully allow the body to heal on its own. Likely not needing surgery at that point, but that would be the end goal. So some other things to think about: lifestyle and diet. Weight loss is associated with preventing GERD for patients who are overweight. People elevating the head of the bed has actually been shown to help for nighttime symptoms. So I think about it as just gravity. If you can't reflux as well because you're working against gravity versus laying down completely horizontal, it has worked for some people. Now, do you want to elevate your bed and sleep kind of at a slant? I don't know how comfortable that would be for most people, but it's something to consider. Triggers can be all over the place. These are some of the ones that are kind of thought of as triggers, but people can have different triggers, of course. So if somebody is getting, well, I always get GERD after I eat or drink coffee or something like that. Well, maybe we can work around that. Maybe take an H2 blocker, when you get up, and then by the time you have your morning coffee, it might not affect you as much. So something like that, you can maybe work around somebody's diet that way if they aren't willing to change. Tight-fitting garments have been associated with this. I'm not exactly sure how that works. I think it would have to be very tight-fitting garments to really cause, I don't know, maybe some Spanx or something. But it's like I don't know. You really got to put some pressure on there, I think, to force the contents of the stomach up. But I don't know. Anyway, you'll see that come up, and they've actually shown that people who wear looser-fitting clothes who have heartburn will actually get less symptoms over time. So, interesting. Things that promote salivation, lozenges and lozenges. Lozenges are gum. Those will help promote salivation over the course of the day and can help prevent heartburn recurrence. And tobacco and alcohol are kind of notorious for causing heartburn. So those things, if you can avoid them, great. But yeah.
Is there a difference between acid reflux and GERD?
I don't know. I don't know what the exact diagnostic criteria for GERD per se is. I think you have to have it a certain number of times for a certain period of time per day, I mean. So, and again, I can't remember the exact diagnostic criteria. But yeah, you could get temporary reflux and not necessarily be diagnosed with GERD as an illness. Okay, so if you do have somebody with GERD or suspected GERD, and again, to your question, I think it comes down to clinically, how is the patient looking and how do you want to manage it? So mild to moderate, less than 2 episodes a week would generally be something where you're looking at as needed treatment. So histamine 2 blocker is what I'd recommend. If they come to you and they're for the last 3 months say, yeah, I get heartburn, not every day, but twice a week, it's just really bad. Maybe they want to take it every day. Maybe it's not predictable with some kind of a trigger, and so you recommend taking the histamine blocker every day. I think always starting with the histamine blocker is best, even if you're going to schedule dose it, because of the PPI risk associated with increasing C. diff risk. If that's not working, or if the patient's still getting increasing symptoms, I would say try a PPI, and usually you're looking at 8 weeks recommended for diagnosed GERD once controlled. So again, the 14 days is silly, but PPIs for 18 weeks. If you have erosive qualities, or you start out and you have more than 2 episodes per week, usually looking at once daily PPI right off the bat, or if it's severe enough. And I would say if it's erosive, that's pretty severe. I'd probably recommend starting with twice daily for maybe a couple of weeks, and then you can go to once daily if things are improving or healing. Pregnant patients, so this is a really common pregnancy-related complication, and PPIs are not well studied in pregnancy. So usually they are used though, so that's the tricky part. Ranitidine is really well studied in pregnancy. Famotidine, not very well studied. So when it comes to OB, if we have any evidence that supports one thing, that's what we're going to use. So for some reason, they studied ranitidine specifically, and we know it's quite safe in pregnancy, so that's the drug of choice. Sulcrafate is fine to use, although it's 4 times a day, so it's not really helpful. And for people who have really severe reflux, they will use proton pump inhibitors for pregnant patients. I don't think there's one that's preferred over the other. I've seen omeprazole and Protonix used, or pantoprazole used. But that would be a subset patient population that would really commonly present with this syndrome. Okay, for ulcer disease, a little bit different, but similar treatment. So we talked about H. pylori already, so 2 weeks of twice daily proton pump inhibitor treatment. And it's usually higher dose than what you might see recommended for GERD. There are other causes of peptic ulcer disease than H. pylori. That's the most common one. So if anybody has ulcers, you're supposed to test for H. pylori and make sure you can at least rule it in or out, and then go from there. Rebound acid hypersecretion is something that can happen with prolonged high-use PPI treatment. So if you have somebody on 2 weeks or more of PPI therapy, if they stop it right away, they're probably going to get residual effects of the drug for a couple of days, and then they might get some really strong acid secretion that comes back. Hopefully the body normalizes that out over time, but it's uncomfortable, so I'd recommend doing some kind of a taper. So take them from twice a day down to once a day, maybe for a week or two, and then stop them after that. It's just to avoid that. To get them down on maybe a lower dose before you're going to stop the drug completely can help with the comfort of that, avoiding that acid hypersecretion syndrome. We talked about these with respect to NSAID use. So we know NSAIDs cause mucosal damage, and risk factors are here. We talked about those already too, and COX-2 having a lower risk overall. But if anybody's on chronic NSAID therapy, prophylactic therapy for acid suppression is generally always recommended. So PPI therapy is pretty much the standard. We usually do a once daily PPI with chronic NSAID use. High dose histamine 2 blocker, and by high dose I mean twice daily, and the prescription strength dose is okay too. And again, probably worth the benefits probably outweigh the risks. So like benefits being ulcer protection, risk being C. diff. Ulcer protection probably outweighs the risk, especially if you're on a high dose NSAID regimen over a long period of time, and you meet some of these risk factor criteria. I'd really strongly consider it. Stress ulcer prophylaxis is another reason why we might suppress somebody's acid production. And again, I mentioned this earlier, but ICU patients, severe illness, severe injury, lack of oral intake, those are all high risk factors for stress ulcers. Mechanisms, acid hypersecretion and alteration of the mucus and bicarbonate secretion happens, and GI ischemia can also cause this too. Just aren't using your GI tract. Whenever somebody is in a situation like maybe a medically induced coma, if we can do enteral feedings, like through a feeding tube, that's preferred. We always want to use the GI tract if we can. Sometimes it just doesn't work depending on what the patient has. Maybe they had a really severe GI surgery, or they've had a bowel resection or something like that. They have to be on parenteral nutrition, so they're getting an IV. Those are the patients at highest risk for stress ulcers in the hospital. So what we like to, and of course, if you have some sort of coagulopathy on board, that increases not the ulceration risk per se, but if you do get an ulcer, you're much more likely to have severe complications from it due to the increased bleeding risk. So if you have anybody on any type of therapeutic anticoagulation, so here I have INR greater than 1.5, but you could think about somebody on heparin, somebody on a new anticoagulant, and then if you have thrombocytopenia too, if your platelets are down for whatever reason, that also puts you at high risk for increased complications due to stress ulcers. So this can occur quickly. It can take several days in the ICU. There's no real way to predict how long somebody is in the ICU before this happens, or how long somebody meets some of these risk factors before it happens. So we prophylax critically ill ventilated patients pretty much right off the bat. And we're going to use oral drugs. If we can use the GI tract, you can put a PPI down a feeding tube. We do have a couple different products. So on the lansoprazole comes as an orally dissolving tablet. So you can mix that with some water and put it down a feeding tube. The rest of them are capsules, and we generally don't put those down feeding tubes. But the ones that come as ODTs, you can mix those as like a little slurry and put it down. Otherwise, we have IV products. So IV histamine 2 blockers are generally preferred for prophylaxis. The reason is because, remember, these patients don't actually have anything wrong with them. We're just trying to prevent that from happening. And IV histamine 2 blockers have been clinically shown to have good evidence for preventing that. And they're really cheap. IV proton pump inhibitors are kind of expensive. So like IV pantoprazole is for some reason brand name only, and it's pricey. It does have some good indications, but for this, it would be sort of a last-ditch effort. But we usually reserve that for actual treatment versus something that is prophylaxis. Okay, so upper GI bleeding is getting more severe here. IV proton pump inhibitors are going to be started, and usually you're going to look at doing a loading dose plus a continuous infusion on a patient. So for pantoprazole, you give 80 milligrams as a loading dose IV plus 8 milligrams per hour. The reason I show you that, a daily dose of pantoprazole for like GERD would be 20 to 40 milligrams. So it's quite a bit higher dosing. And the studies have shown that if you really hit somebody with a massive amount of PPI right off the bat, you do raise the pH substantially over if you were to dose them traditionally. And the other trick is do we do big boluses of dosing or do we do continuous infusions? So currently, continuous infusions plus a bolus initially are pretty popular choices. However, there is some evidence that shows if you give somebody a really high dose of pantoprazole, like give them 80 milligrams and then 8 hours later do another 80 and then maybe do twice daily 80 milligrams, it's still a lot of pantoprazole and it's shown to be relatively effective too. So some institutions might prefer that. It's cheaper than doing continuous infusions and easier to manage that way, but it just depends on where you work. Like we do both. We'll see both depending on the provider's preference. So. What else about this? Octreotide, I'll just mention this very, very briefly here. So if you have an upper GI bleeding due to variceal bleeding, mostly this would be seen in alcoholic patients. Acid suppression hasn't been shown to be quite as effective at preventing that bleeding. So in those cases, octreotide is a little bit more of an advantageous medication. I know we haven't talked about this very much, but I'm just going to mention it very briefly because it's got kind of a limited role. But octreotide mimics somatostatin by inhibiting serotonin release, and by doing that, it inhibits a number of things. So gastrin, insulin, glucagon, secretin. So we get a number of different alterations to GI-related peptide hormones that is going to allow the GI tract to heal and prevent that bleeding from getting worse and those varices from breaking open more. So anyway, octreotide is one that we see used for that, but it's kind of got a niche indication there. All right, combination therapy. You can mix and match most of these. So PPI and H2 blockers can be used together. The recommendation is that you split them up, though. So if you're going to combine them, recommended PPI in the morning, H2 in the PM, that's okay. You just don't want to get them together. Remember that histamine receptor blocker works quickly, and if we're shutting down some of, because it's got an indirect mechanism of shutting down that ATPase, and if we do that early, the PPI is not going to be as effective. So if we can do the PPI right away in the morning before your first meal, and then do the histamine 2 at night if you need some extra. That's a common dosing strategy for combining these two. You could, of course, do PPI BID, but some patients might like the different response there. You might get some added benefit from the two mechanisms that way. But most people don't need this. I always think if I see a patient on multiple acid-suppressing drugs, I always ask them why they're taking them because I don't really understand. I know that there's some patients that try things and it doesn't work, but how do people get on high doses of both drugs? It's always something you should interrogate, I think, as a provider or healthcare professional, just to make sure it's appropriate. Because in most cases, you should be able to simplify that down to one medication, but not always. So I always think it's a good double check. It's a little bit of a red flag for people who are doing it. And these are OTC, so it's not out of the question for somebody to be self-medicating aggressively on these and not consulting a healthcare provider doing so. All right. Any questions about acid suppression? Yes.
So on your chart, where you're telling us like what to do first, is that really just short-term treatment, right? Because it says PPI for 8 weeks.
Yeah, once you do it for 8 weeks, you could reassess then. So the question is, I think it'd be clinically, were there specific triggers causing it? Is it something that you need to continue chronically at that point? So that would be just a clinical decision you have to make patient to patient.
You could say the H2 is fine.
Generally speaking, yeah, you still have the risk of interring, but yeah, and a lot of people take these chronically too. Remember, we have large amounts of patients using these, so the C. diff risk, while high, it's going to be still pretty rare to see your patient get C. diff out of nowhere on a PPI, but it does happen. So. All right. Talk about Crohn's disease a little bit, then we can take a quick break and finish up this one. Pull up this one.